All right, welcome everyone to the live session number 4 of the Sahlgrenska Global Health Hackathon. Today is going to be about challenge number 1, health equality, bridging gender and ethnicity gaps in access to care. So, like all the other live sessions, here's the agenda. So after my short welcome, we will salute the hackathon. So Jamie Smith will come on the floor and we'll tell you a little bit more about the hackathon itself. And then we have our amazing speaker for today, which is Christopher Ball, Biotech Client Partner at IQVIA. And he will talk about for about 20-25 minutes. And after this, we will have, as always, the Q&A sessions. All right, so let me tell you about the house rules. So as for the other times, this meeting is being recorded and we will make it available on YouTube and Event Tornado. You can find it under the live sessions tab. Questions. So you can ask your questions anytime during this meeting. You can use the chat functionality here in Zoom, but we will address them, as I said before, during the agenda, during the Q&A session after the speech of our speaker. All right. So now let me introduce you, Jamie Smith. Hello, Jamie. How are you doing?
Hello, Michele. Thanks very much. Yeah, we're connecting Sweden and Spain and the UK here today from the presenter's perspective. And I know we've got a nice international crowd on the line as well. And we hope there'll be a lot of people listening to or watching the recording of this as well. But thanks so much. And just a brief introduction before we get into the main part of this webinar today. But the Sahlgrenska Global Health Hackathon, for those of you who haven't heard about it already, so it's a series of on-site weekend innovation hackathons. So everybody's welcome. You don't need coding experience necessarily. We just want people to bring ideas, interest, and insights. So sign up and show up, and we'll take care of the rest. We're getting the question quite often, so what is a hackathon? And as we see it, so it's an event where people come together to collaborate to solve a problem or identify new opportunities, and anyone can join and make a difference. And in our experience, where we've been bringing different people with different profiles and different backgrounds together as part of these hackathons is where the magic can really happen. So iterating ideas and discussing ideas from different perspectives is very, very cool and usually a lot of fun as well. So we encourage people who might be interested in joining a hackathon, whether it's their first one or whether they've done a lot before. So welcome to this Global Health Hackathon. And as you can see on this slide, we're planning to visit 6 countries across 3 continents and 10 innovation hotspots. You can see the dates there. But yeah, let's, and maybe the reason why we're doing this as well is because we need fresh new ideas to tackle some of the world's most urgent healthcare challenges. So it's a very noble mission. And we're very, very excited to be able to, get this moving and bring people together to hopefully come up with the next big thing in health innovation. Okay, Michele, if you could move to the next slide. These are the focus areas that we're zooming in on. So health equity, fighting cancer, healthy aging, infection prevention and control, and smart, safe, and sustainable healthcare. So they're broad and they are very pressing from a global perspective. So anything we can do to help come up with solutions to address these problems, I think will be fantastic, amazing. So we're going to zoom in today on challenge number 1, which is health equality and access to care. So globally, health gaps based on gender and ethnicity, they continue to impact access to care and health outcomes. So what do we mean by fair healthcare? What role does gender and ethnicity play? What approaches could have an impact? We're delighted to have with us today Chris Ball. He's dialing in from the UK. He'll help us explore what the data tells us and the implication for developing new products to improve health equity. So Chris is a client partner at IQVIA. I hope I said that right, Chris. And he's working with biotech and public health organizations. He's got 25 years of working in life science commercialization across diagnostic and therapeutic companies. And he's previously worked as a UK medical doctor, a clinical epidemiologist, and a strategy consultant. So who could be better to take us through this challenge, provide us with insights? Chris, over to you.
Thanks very much, Jamie. Good afternoon, good morning, good evening, everybody. Let me bring up my slides and then we can get going. So look, the first question I think that is worth asking is, what do we actually mean by fair healthcare? It may vary between different people. So it depends on what your focus is. It could be how long somebody lives. It could be the quality of life. It could be access to healthcare, or it could indeed be the costs of healthcare. All of those can be measured in different ways. Now, thinking about that has an effect on what kind of solution you're going to develop. You may think about doing all of these, but it's something just to bear in the back of your mind as you move forward. Now, what I want to do for the rest of this talk is focus on the three areas that Jamie mentioned: money, wealth, ethnicity, female sex, and what ultimately can you do about this? But what are those three factors and how do those have an impact on health? And what do we know from the data? So let's start with money. So this is a graph from the Gapminder website, which some of you may know is Swedish in origin and pulls together data from lots of different countries around the world to help understand long-term trends. And what you're seeing here is GDP per capita, so how much money does a country have, versus life expectancy. And as you can see from this graph, very clearly, as countries get richer, people live longer. That's great. Now, of course, even within a country, you can recognize that there are clear differences again between the rich and the poor. But this is a very obvious message. Wealth matters. Now, let's dig in a little bit more in terms of then starting to understand, okay, fine, rich and poor, where are there differences between the diseases that affect people in rich and poor countries? So there is a report University of Washington reproduces every few years. This is the last one from 2019, describing the global burden of disease. And broadly, you can break this out into a number of big categories. The first is non-communicable diseases like heart disease, diabetes, kidney disease. That affects most people in the world. Communicable basically means infection, and injuries is obvious in itself. But here's where it starts to get interesting. If you look at the richest billion and compare it to the poorest billion number of people, you see significant differences in terms of what diseases affect them. Poor people basically die from infections and treatable causes of disease. But of course, there's a large number of people in between. The 5 billion people who live in the middle, what are they affected by? And what you can see is that as people become richer, non-communicable diseases become much more important. And this is traditionally where most money has gone. Billions of dollars a year are spent on trying to treat these non-communicable diseases for the richest people in the world. But what you can see is over time that infection becomes less and less important. And because countries are becoming richer, infection as a factor, though still important for that lowest billion people, matters. And you can see that in other charts from Gapminder. On the left, you've got basically people's size. And as you can see, as you get richer, you get fatter. But on the right, this is where it starts to get interesting. You can see that in the working age, 30 to 70, roughly, what's the chance of people dying from those non-communicable diseases? And you can see a U-shaped curve there. You can just about see that. That there is an increased risk of dying from non-communicable diseases without a health system to support it. And indeed, in Africa, it's likely that by 2030, the commonest cause of death is going to be from non-communicable diseases by 2030. So this is a problem that is here already. Okay, so that's wealth, clearly an important factor. The next is, let's turn and think about women. So, and in some ways this may sound obvious. We know that men and women have different experiences of diseases, but actually when you start to look into the clinical literature and ask the question, well, what differences, it becomes actually very hard to understand. There are very few studies that have looked at this. This one from Denmark uses national data and looks at that specific differences. Those different colors you see here reflect different categories of diseases. But if you look at men, compare it with women, then you can see two things, first of all. First of all, when the diseases happen, occur very differently. And secondly, what kinds of diseases affect people through life. And so you can see, particularly with women, it's interesting that they present later with many diseases, and the way they present is different as well. So if we take chronic lung disease as an example, women are typically presenting 9 months later than men on average. And the way they're presenting with breathlessness, whereas men present more often with cough. Now, why does it matter? Because women are at increased risk of lung failure, basically dying from breathlessness. So not understanding how and where these patients are coming from based on the different sexes has effects. Now, the reality is we observe it, but we don't necessarily understand it. So let's then go on and ask the question, if we're not understanding it, what implication does that have for scientific research into these different diseases? So what I've done here is take a paper that looks at where money is being spent in the US based on diseases for clinical research. And what you see is I've categorized them out by diseases that affect men more, diseases that affect women more, and ones that are roughly balanced. And then ask the question, okay, amount of money spent versus what's the disease burden? And basically what you can see is that for every dollar spent on a male-dominated diseases, it's about 2.5 times more than ones that affect women. But when you look at the balance, you can see that for many, many common diseases, it's not enough. So the message that comes out of here is the current funding is unfair, and it's certainly unfair compared to men versus women, but it's unfair overall. And if you were actually going to reallocate money, you would pull money away from both male and female diseases. It's not a brilliant correlation, so clearly there are other factors there, and we can obviously think about those, but nonetheless, it shows that there is some mismatch there. And what's the consequence of that mismatch? Well, when you look in a clinical pipeline and you focus on diseases that affect women only, female cancers and conditions that affect female reproductive system, you can see that there are big differences. Now, in disease, on this chart, you're seeing on the left diseases that primarily kill people, and on the right, you can see diseases that primarily cause suffering and long-term disability. And what you can see is that in the cancers, it's pretty good mostly. Not in pregnancy, and definitely not in conditions like endometriosis or uterine fibroids. Endometriosis, we know, affects 200 million women a year around the world. And yet there's hardly any treatments available for it. You could ask, why is that? This is sexism. Maybe it is. But these are also complicated conditions, which may reflect the fact that there's been little research done. It may reflect the fact that many conditions where people suffer are often not as well reimbursed as ones where death is a very obvious and an easy number to assess. Nonetheless, again, there's some kind of challenge here. So you might then go on and say, well, doesn't that mean that women are not participating in clinical trials? Not true. Generally, certainly in North America and large parts of the world, apart from the famously egalitarian Nordic countries, which seem to do poor in this, female participation, certainly in the last 20 years, has been roughly equal to men in clinical trials. Sounds good. However, when you start to dig in and ask the questions about what diseases are actually being treated, you start to see imbalances. So let me take the top one, musculoskeletal and trauma. Now, trauma, this mostly affects men, but women are more likely to participate relative to the disease burden in that clinical trial. So women are overrepresented in a disease where men mostly have the problem, but they're underrepresented in things like cardiology and oncology. That's well recognized in cardiology. So we don't have a balance if we think that disease burden is the most important way to measure. But even if you're just doing it on basic absolute numbers, again, it's not balanced. And it starts to become more important when you realize that maybe 30% of pivotal clinical trials, ones that are used by regulators to approve new drugs, 30% of those have significant underrepresentation of both women and ethnic groups. So there is some kind of challenge. Right, and now let's move on to that ethnicity question. So first of all, let's look and ask the question very simply, what do different ethnic groups die from? This data is from the UK. And what you can see broadly is that it doesn't matter what ethnic group you are, people mostly die of the same things. But there are different weights there. So again, probably very familiar, South Asians are increased risk of heart disease. Black Caribbean men are increased risk of prostate cancer. And as we see, white men are at increased risk of many other diseases. There's obviously lots of other factors involved here. And I think the most important thing to say is the amount of melatonin in your skin is a very poor predictor of what you're going to be affected by. There are lots of other factors involved: culture, diet, and genetics. It's worth emphasizing here that the genetic diversity within Africa alone is greater than the genetic diversity in all of the rest of the world. So to describe somebody as simply Black African removes a lot of nuance and understanding about how genetics affects disease. And we know that for sure, as opposed to the amount of melatonin in someone's skin. But let's go on and move on from the, let me say, the biology side of it to the social side of it. What do we know about the impact of racial differences on access to healthcare and perception of health? This data is from the US, and I think this is maybe a story more of minority groups, but what you can see is that Black and Latino people in the US have persistently, over the last 20 years, described poorer states of health than whites or Asians. And they're less likely to be able to pursue health for various reasons. You can adjust for income, and it is a big factor, but even accounting for that, poor Blacks still report lower health status compared to similarly poor whites, and poor Hispanics have less access to healthcare. Again, you can start to hypothesize reasons about that. But what I would say is that I think it's important to recognize that ethnicity is a component, but it's mixed in with many other factors. So to use that as a simple measure, and again, we'll come and talk about that a little bit later, is a really important to not overemphasize it, just to recognize things in the round. So the next question, of course, is, because we have this genetic diversity, it's really important, and regulators are recognizing this, to have these kind of groups participating in clinical trials, because otherwise you don't get a fair representation of either treatment benefit or potential risks that come from it. This chart is looking at, what is the likelihood of somebody having cancer, dying from cancer in the US, and you can see by that there is a difference, again, but for Black and Hispanic people in the US, often a greatly increased risk, particularly for Blacks, compared to the white population. And then on the y-axis, what is their relative percentage of participating in clinical trials, with 100 being at the right level. And what you can see from the right is persistently, Blacks and Hispanic people are not participating at the right level to take part in clinical trials. So there we go. Money, female sex, ethnicity, all have components to play and often are intermingled. So what can you do that actually can practically have a difference? Well, let's sort of summarize what we've learned first. One, that wealth and biology matter, melatonin less so, at least from a biological perspective. We know that people in richer countries live longer. In fact, we could probably just say richer people live longer. Women and men have different experiences around disease, and we don't actually really understand that. And then we've got this complexity of you add in ethnicity, you add in other factors, and you suddenly start to see certain groups who are definitely being excluded from access to healthcare, definitely being excluded from access to research that benefits them down the future. And as we're seeing, disease does not align well. Disease burden and research spending do not align well. And there are questions about how could we improve that. And then finally, clinical trials don't really reflect that diversity. Maybe okay at a high level, but as soon as you start to break into it, you're seeing that there are significant groups that are missing, particularly ethnicity. And those have factors that should affect us all, because genetic variation means differences in terms of how people respond to treatments, and we need to understand that. So what things have people done to try to improve health inequality? This is from a systematic review that tries to summarize different approaches. And it's worth saying that most of these are not based on trials or formal assessments. It's mostly modeling or reports. So you have to understand that the data can vary, and certainly the success of these interventions vary, but broadly they break down into 4 big categories. Number 1, empowering individuals to take responsibility and be aware of their health. The second is then taking the existing systems and making sure that there's the right coordination, the right IT systems, and the right training for clinicians. The third is about proving access, whether that's through money or better governance. And the fourth is recognizing that for some groups, you just need to do things in a different way. That might be in a different time, in a different location, or indeed a completely different approach. You'll see here that I then highlight some examples that I briefly want to talk about now to sort of give you a sense of some good stories, some bad stories, but at least a kind of breadth of what people do. But I think it's important to emphasize that often, there's not just a focus on one approach, there's often multiple, because these are complex interventions, and therefore trying to change one bit, you often need to have an effect on other parts as well. So the first story comes from Genentech, who focus on breast cancer. And they recognize in the US that Black and Hispanic women are at increased risk of developing breast cancer. And the breast cancer they develop is often diagnosed later, and it is of higher risk, so their mortality is higher. So there's an importance to get them to screen. So what they did was to invest in a program where they took Black and Latino artists, combined them with personal letters written to loved ones by women from these ethnic groups, to try to create an emotional connection and need to encourage uptake. And this has been now rolled out across 16 states and is, again, driving an awareness. How easy it is to track, I don't know. And obviously you've got a large company supporting it. But, the message is, really focusing on these groups can actually start to help and make a difference. Let's then turn and talk about data and algorithms. Now, obviously, that's potentially an area for this hackathon. Use the information to guide identification of high-risk groups or identification of groups that may respond better to treatment. Excellent. You do have to be a little bit careful. And I'm just giving you an example of an algorithm used to measure renal function. So doctors like to look at something called creatinine clearance, which is frankly a painful, not particularly complicated, but just unwieldy method to measure directly. So typically what doctors will do, and to do something quickly, they will take some numbers and estimates, put them into a little algorithm, and out pops an answer that says this is the creatinine clearance estimate. Now, one of those that was developed and used for many years relied on race, Black status, because essentially it's recognized that many Black people have higher levels of creatinine, so you want to adjust for that. Sounds good. Maybe. But what was discovered that after they've been using this for several years and using it as a criteria to enter patients for renal dialysis and renal transplant, that Black people were less likely to actually benefit from it because of this negative factor that was used. Changing the algorithm and adjusting it so being Black was no longer a factor actually then led to more Black people being referred for dialysis and transplant. So it's really understanding what are the factors, and is the factors you're using actually biasing for and against different groups. And the final is a message around data. So the Christie Hospital is the best cancer hospital in the northwest of England. And you would hope that patients would get referred for it because they're going to get the best treatment. Now, this was an analysis that IQVIA did on NHS data and looked at where did patients get treated. And what they found was that often they did not get to the Christie. So Bolton, which is 30 kilometers away, so easily travelable, a third of patients did not receive the treatment. And what you also saw was that many patients were not even getting directed to the right hospital, and that there was a big factor that poverty, deprivation affected whether they got the right treatment. So again, this is coming down to this message of data and how it's guiding what should happen for people. Let me finish now with this focus on some things that you could do to focus on better, more equal healthcare. Number one, focus on the gaps. And I think you've heard me say a lot of times, we just don't know. We don't have the data. We don't have that link between clinical, social factors that could start to guide what's going on. There are many underserved conditions where we've not really thought about the disease burden, or we haven't identified conditions like endometriosis, as an example, as ones that should have more investment and more resource put against them. Similarly, there are communities out there that are simply not being represented, and it's important because we need to understand this to make sure that every patient who receives a drug is receiving the right one and it's safe for them. That translates then into clinical trials. Are we focusing again on the right areas? Are we aligning, making sure the right patients are getting access? Are we getting the patients at the right point in their life cycle? And are we looking at the right factors? And finally, are we encouraging these patients? Are we creating environments that they actually want to participate? And then finally, ensuring access. And let's not forget, there's no point in developing all of these products if in the end, people cannot benefit from them. So understanding how patients actually eventually get referred to a point where they see a doctor and have access to the therapy. What is causing that? Is it cost? Is it misinformation? Is it fear? Is it a failure to diagnose? Is it a failure to actually treat in the end? They're all important. And I want to finish by leaving you with two ideas. The first is thinking very clearly about how do you actually make this sustainable? It's all very well that we can often think about health inequality as something that has to be done as a charitable benefit. But the reality is, if you can create something that is a business that does good through it, that's really important. That can then create a long-term value. And the second then comes down to thinking about how do you scale? Because there's potential here to benefit millions of people a year. I said endometriosis, 200 million women a year suffer from that condition, and yet there are hardly any treatments for it. That's opportunity. How do you build out the scale that comes from that? There we are. That's a very quick run through a very complicated topic, but I hope it starts to give you ideas of where you can go. This is an incredibly important area and can change lives. Jamie, back to you.
Wonderful. Thank you so much, Chris. And it was, you've opened my mind to sort of the nuances in this topic as well. It's just not clean cut. And I think you're inspiring how you've taken a look at the data and coming up with drawing conclusions and challenging people to kind of think about what they see and their preconceptions around this. So thank you so much. It was a short time, but I think you gave us a really rounded view into this topic. Thanks so much.
Pleasure.
So please, people on the call now, if you want to post questions in the chat, or if you want to raise your hands and say verbal questions, then we'll be on the line for a few more minutes. I can't see anything. Michele, can you see any chat questions so far?
I don't see any chat questions so far. Yeah.
Maybe I can ask you a couple of questions then, Chris, in that case. So
Sure.
you mentioned Genentech, and I think they're part of Roche now. But what do you see? So in your role as a biotech client partner, but with the pharma companies, how are they taking on this topic? Do you have any good?
Look, they're increasingly recognizing it as not just a nice to have, but something that is actually increasingly commercially important. And look, as you've heard, Africa as an example, as a country where non-communicable diseases are going to be the key cause of mortality, within 6 years. There is huge opportunity there, and companies are starting to recognize that with that, there is, if you can get the economics right, not only is there a moral imperative, but you can also generate business. Obviously, it varies in terms of where companies are in terms of their thinking about this, but certainly the most sophisticated ones are investing heavily, both in terms of their people, their systems and their resources, and also recognizing that we need to upscale many of the health systems in these countries to help them actually manage that capacity, because the reality is at the moment, they're struggling.
Yep. And I can also mention it. So AstraZeneca are one of the global partners for the hackathon. And I know that it is an important topic for them. I don't know details, but I know that they do talk about that a lot. Yes. Okay. Any questions coming in? No, it doesn't look like it on the chat. People are a bit shy today, but wanted to ask you. So, but if you were participating in the hackathon, Chris, and maybe it'd be fantastic if you wanted to. But what specific problem related to health equality would you focus on solving?
I'd probably think about two areas. One would be this data challenge. The reality is that in many countries, we simply don't have the basic information. Now you're going to say, oh, well, of course, we understand that for some of the poorer countries around the world. Yes, you're right. But it's also many of the richer countries as well. You look at that, the Nordics maybe stand out because they do have very good data, but many countries around the world, you just can't ask some very basic questions around what drugs work, what patients respond. Are we actually getting the right treatments to the right people at the right point? So I think that, people should not be surprised that doing some what almost sound trivial things, actually, if you can do them, can have huge impacts. That's the first area. The second, I think you've heard me talk about it, is conditions that have no real treatments today, but significant impact. Endometriosis being one. Now, I'm not going to trivialize the complexity of the biology there, but my point is that there are conditions out there where there are large opportunities that for whatever reason today we haven't treated. And if somebody can come up with solutions that are attractive, that has big social and economic impact.
Yep. Great. It's a challenge for people watching this webinar.
That's it.
Very good. And the sort of last question for me. So if someone's watching this webinar and they're kind of going back and forward whether or not they should participate, what would be your message to them?
I think this is an area where you can have enormous impact. I think that's probably the key message. The number of lives that you can affect if you come up with a solution that could be huge. It is also aligning with, as we've heard, large corporate areas direction, but more importantly, it's aligning with that global trends. That information that I showed you from Gapminder, there's lots of other pieces of data that you can pull from that, but it all shows two things. And I think the positive trend is things are getting better in the world. I think we can often feel that they're not. When you look at the data there, it's substantially saying that people are becoming richer and living longer. But there is that gives opportunity, and so helping those nations, helping those people who today are not accessing healthcare in the right way, at the right level, again, can improve the world for the good and potentially also generate good profits for some people.
Yep. Very good, and we're very proud of Gapminder in Sweden, in the Nordic countries. The Rosling legacy lives on there. Fantastic. Great. Okay, so any other questions before we wrap this up? Let's see. Any questions, comments, ideas, feedback? Thank you for today. Thank you, Eleanor. Very good. Okay. Great, but Chris, thanks so much for informing and inspiring. Michele, maybe you can wrap. There's one question I think just popped in just before we wrap it up. Let's see. There we are, Lena. I have a question about the imbalance in access to modern and high-tech medical equipment for the disadvantaged in remote and less developed areas compared to urban areas. I'm looking at it from the perspective of developing countries. Do you have any comments on that, Chris? A question about the imbalance in access to modern and high-tech medical equipment.
Yeah, so I can sort of say in two levels. There was a case I was going to talk about, Push Doctor, which is one of these telemedicine solutions that was being developed recently. And that can be touted as hey, here's a solution that can allow disadvantaged people to be able to access the doctor. But the reality is, when you actually look at the evidence, it suggests the opposite. Because if you're disadvantaged, you may not have necessarily access to the technology, the equipment that allows you to have those conversations, or you may be even more reluctant to actually engage with the healthcare. So I think it's important to say that tech solutions by themselves may not solve all of the problems in the world, whatever people in Silicon Valley may say. But I think the counterpart to that is that we have seen the uptake of mobile phone technology around the world as a huge benefit. It has put capacity and capability into the pockets of people who previously had no great access to technology. I think when you start to load AI onto that, you can start to see that potentially there could be significant changes in the way that people could access information around healthcare. Now, obviously, in terms of accessing medical equipment, that's another question, which is dependent on many factors. But let's be honest, there are many interventions that can be done before you start buying robo-surgeons and the like that could have real benefits for people. So it's actually being thoughtful about how to intervene and what to do and how do you support health systems in the right way at each local area. So not a great answer. I know it's a very complicated space, but I think we see both positives and potential challenges there.
Great. Thanks, Chris, and thanks for the question. I think that could be something to look into as part of the hackathon as well. I think it's very remote areas and access to technology and to care. So great. If there aren't any other questions, we're going to try and wrap up on time. So last chance. Michele, over to you to wrap this up and tell people where they can find more information.
Absolutely. So here in the chat, I pasted all the links. We have a webpage, of course. In there, you can find all the information about the hackathon. Follow us on LinkedIn. Follow us on Instagram. You have the handles there and the link. And also, if you're not registered yet, it's very easy. You go to eventtornado.com/events. You select your local hackathon and you click on the register button and you're in. That's it. Maybe some few words about the amazing partners, Jamie. Yes.
Yes. Thanks, Michele. And here they are. These are our wonderful, amazing, fantastic global partners and local organizing hosts helping us to roll out this hackathon. You can see we mentioned AstraZeneca, but Microsoft are with us as well. R3, Mölnlycke, Boston Consulting Group, Business Region Gothenburg, GoCo, Precise EU, exciting EU project, Sahlgrenska Science Park, Sahlgrenska University Hospital, Sahlgrenska Academy, and Sweden Bio, and then the local organizing host. I saw Shell was on the call as well. So hi, Shell, and looking forward to coming to the US to see you soon. So we're really very, very grateful for all the fantastic support we're getting from these 6 countries around the world. And also to you, Michele, our hackathon platform guru. Event Tornado is the platform we're using, and it's a fantastic tool for organizing hackathons. So with that, exactly on time. So thank you, Michele. Thank you, Chris, so much.
Thank you, guys.
Presentation, and thank you everybody for participating. And come and join us at the hackathon. It's going to be fun.
So, thank you so much, guys. Bye-bye.
Bye-bye.